be on Zoom.
Okay. Well, in 5 minutes or so, I'll just get out of this screen and I'll double check. So
And I'll pay attention to my phone. They might text me and say that they're waiting to get in or something.
sounds great. Well, we will get started nonetheless. So it sounds like a party in there, number one. Everybody's having a great time. Yeah. Getting Chipotle, nobody can get seconds because they're going to go right in front of the screen, but that's okay. And everybody at home, I hope you're enjoying with whatever you're eating for dinner tonight and maybe an adult beverage. I don't know, but it's gonna be a lot of fun. So thank you, Bridget, for having me speak with your group tonight. It's been a while. I did a few years back and it just seems like yesterday. So and I know our team really enjoys speaking with the students at MSU. A couple weeks ago, I spoke to the pre-dental hygiene students, so that was a lot of fun. And a fun fact about me is I started my college career at Mankato and MSU. And for those of you who remember the Gage Towers, I was in Gage B, I think like 12th floor. I can't remember what floor I was on. But had a great time. And again, that's where I started. I ended up graduating from the U of M School of Dentistry within dental hygiene. And I'll explain a little bit more about my background here in a bit. I also wanted to thank Nellie for inviting me to speak tonight through Solventum and 3M. I met Nellie through a lunch and learn. I had a private lunch and learn for a product that I was hearing about with all of my clients. And it was a new fluoride varnish that was water-based, and I had to do my own research on it. And the awesome thing about being a practice management consultant and working clinically is that any product I advise or recommend to my practices, I research myself. I get my own little private lunch and learn where I grill the reps on all the questions that I'm going to be asked. And then I get to use it on my own patients and see the results. So we have had a tremendous increase in fluoride varnish acceptance ever since we started using the ClinPro Clear. And there's so many good things about that. So maybe Nellie, if you have time today, if you are in person, you can connect with her and learn more about the product. And I'll maybe talk about it a little bit more as well throughout my presentation here tonight. So the topic of dental hygiene has been a hot topic for many years, and especially now, tight labor markets, not just in dentistry, but in everywhere. Compensation, keeping up with compensation and inflation, right, after 2020, and especially the last couple of years. In addition to those particular practices that are participating providers with insurance, the reimbursements aren't going up. And so we're stuck in this predicament of how do we compensate not only our hygienists, but our team through capitalizing on coding correctly in the low-hanging fruit within the practice? And how do we make all of those puzzle pieces work together efficiently? So some of the CEs that you go to and that I go to, you come back with like maybe two or three pearls. Literally every slide that I have is all of the pearls of dental hygiene and coaching a dental hygiene team. And I am confident that tomorrow, if you guys are in practice tomorrow, you can go back and implement a few things right away. Um, a couple housekeeping items with that. This is virtual, and so it's really hard to field questions during the presentation. If I was in person, I'm totally like, hey, let's bounce ideas off of each other. This is going to be interactive. So if you do have a thought, a question, an experience you wanted to share, because I want to hear those too. I also learn from my audience and my clients just as much. Write those down, and chances are I might be covering it in a later slide. But write them down nonetheless. The same thing with all of you on Zoom. I'm not going to have my chat feature up that much either. So write your questions down and we can address them at the end. I hope that's okay. I'm planning to get done around 7:30, 7:45. And so after that, we will have an entire 30 minutes, hopefully for Q&A, so you do not feel rushed. If you don't feel comfortable asking a question in front of everybody, or it's proprietary to your practice, or we just simply run out of time, I would be happy to jump on a call with you and schedule a call to dissect your question for me. So I'm totally open to that as well. A couple people ask sometimes if they're able to have me to email the presentation. I don't typically do that, but feel free to take pictures or screenshots or whatever you feel like is relevant that you might want to use or you want to store for notes purposes. So I'm totally open for that. So, a little bit about me. For those of you who I haven't met before, my name is Shannon Snell, and I own two businesses that serve private practice dental offices. One is called Dental Recruiters, who used to be Crown Dental Staffing. We are one of the largest temporary staffing agencies in the Twin Cities. We have since dropped the temporary temp aspect of our business, and we're focusing primarily on permanent placement recruiting. So any practice that needs a dental hygienist or a dental assistant, we place a lot of associates, practice managers, front office individuals, unlicensed assistants, anybody that is within the dental practice, we help hire. And these could be clients that really don't have the time to commit to hiring and putting an ad out and interviewing. There could also be, we have a lot of clients that have done it on their own, but have been unsuccessful. And so then we'll hire us to help them with that. We'll do ad design, recommendations for benefits and wages. We do preliminary interviews, background checks, all of it. So we send these nice little candidate packages over to the practice and just help with that whole process. Dental Recruiters is ran by Erin Nutt, who is also a dental hygienist from the University of Minnesota. She is awesome and really takes charge with that company. And so we're very proud of what we built with that. Dental consulting company. Can't you tell? I just name my businesses for what they are. It's kind of like the Container Store. You're wondering what they sell there. Dental consulting company, I spend 98% of my time there, and we are a practice management consulting company that works with established practices, and we also work with practices in transitions. So established practices have been in business for a while. They are wanting to improve maybe their profitability or their patient health outcomes, or they want to start coding correctly, capitalize on the low-hanging fruit within their dental hygiene department. Maybe they are like, hey, I don't know if I need to hire another front office person. Can you help me streamline the tasks that are being done at the front office? So we'll help with that. Or we'll get a question of, hey, I'm not liking my write-off situation. My reimbursements aren't going up. Can you help me negotiate / potentially drop some insurance plans that I'm in network with? And so we'll strategize with them, financially forecast what that looks like so they can do it in a very safe way. And then also coach their team on what that transition looks like to get out of insurance plans and that it's not negative, and making the patients feel comfortable and the team feel comfortable with that. In transitions, what that means is we work with buyers of practices. So as we started our consulting company years ago, we worked with established practices only. And one time an attorney reached out to us that brokered practices, and that's kind of like in the real estate world, it's a realtor that's selling a house. And they reached out to us and said, could you help my client credential? And credential means like get them signed up with the insurance companies that the seller that's selling the practice is in network with. And we said, sure, we can help with that. And so that led to one doctor to another doctor, and it just escalated from there, where we found ourselves in this transition space of dentists that are looking to buy a practice. They need help with the credentialing piece, but they also need help with so much more. What am I buying? How do I become a good leader? How can I really set my team up for success? I'm new here. I'm inheriting this team. So we really hold their hand along that transition. We do due diligence audits. So a buyer that's looking at a practice and really wants us to dissect the numbers for them, we'll do that. And then one of my favorite parts about being in transitions is we have a lot of startup clients, which I couldn't be more honored that I'm working with a dentist that literally bought a plot of land without a building, potentially sometimes, no patients, and they're leaning on us to say, hey, how do we run this thing? What do we need to build? How are we going to be successful? So that is a little bit about what we do. I own these two businesses, and I am also an actively practicing dental hygienist. And so that is great because it allows me to be relevant when I'm speaking, and it allows me to be relevant with our teams. I speak every fall with the D3 students at the University of Minnesota, and we go over 76 ways to kill case presentations. And all of it is a lot of fun. Aside from what I do on a professional level is I love my family and I love family time. And as you can see, I have a few children. My oldest is 10 and our twins are 3.5. So I'm also a busy mom in owning a business and know how to, I don't like the word balance, but set boundaries between everything to make sure that I don't get burnt out and that I'm carrying a lot of positive energy for my family as well. So just a fun fact, after our first 3 children, my husband and I said that we were done. We gave away you guys already know where this is going. We gave away all of our baby stuff. I mean, everything, the crib, everything. And then one day I said, you know what, Jim, I want a big family and I'm too young to make this decision to not have any more children. And let's just have a fourth because then everybody will have a partner on a ride and it's going to be an even number and it's just not going to be an issue with our vehicles, whatever. So then fast forward to talking him into it over a year, we ended up with a buy one, get one, I call it. And we got twins it was a surprise for us. So never in my life did I think that that would ever happen to me, but we couldn't imagine life any other way. So we love it. And my daughter Millie here in the black, some of you who may have heard me speak before, she is very curious about what mom does for a living, and she comes to 1 or 2 of my speaking engagements per year. So, and last time I spoke in front of oral surgery group, on the way there, she goes, Mom, I really want to speak tonight. And I said, okay. So she practiced in the mirror and she got up there and she did wonderful. My name's Millie, I'm 8 years old and I love hockey. It was something like that, but it was so super cute. So she'll be working with me someday, I'm sure. She just loves what mom does. So in tonight, we are going to be covering a few different things. I'm going to be talking about how the dental hygiene profession has evolved over time and how innovative advancements have helped dental hygienists. Dental hygiene compensation, that's always a hot topic. So I have strategies on how to measure if you're paying your hygienist too much or too little, and what does their production look like in reference to their compensation. I understand that your area might be different than a different demographic in terms of compensation, but yes and no. So there's factors in that we're going to unpack. If you have questions, again, when I go over this, write them down and we'll go over it at the end. Profitability markers. How is a dental hygienist profitable within their chair? What things are we looking at? Yes, every time I'm coaching a practice or I'm speaking, I always want you to know that number one, anything that I would advise, recommend, want a practice or a practice owner or a hygienist or even a dental assistant to implement comes from a place of providing comprehensive preventative care for our patients. I know that if we do that, deep down, if we do that, the revenue is a byproduct of that. So those of us who comprehensively treat our patients, I don't even have to ever talk about production with our practices because that will just go along with it if we're doing it what's in the best interest for them and from a preventative, not a reactive approach. We'll talk about needs assessment. A lot of times, even for front office, assistants are a little bit more predictable, but front office and hygiene, we make hiring needs based off of feelings. Like, I feel like I need to hire another person at the front. And then I'll say, well, so what is everybody's role description? What do they do on a daily, weekly, or monthly basis? And they're like, well, we don't really have those. And I said, well, that would be step one, because we don't want to continue to add people when there's not clarity in what we do. The same thing with hygiene. Okay, I'm booked out 3 months for hygiene. I feel like I should hire another one. And I don't want us to make any business decisions based off of feelings. I want us to look at numbers and what those look like to see what our hiring needs are and how many actual hours or days of hygiene that we need. I cut this number 6 out of the presentation, one, because it's just too long for tonight. But also October 9th, I'm doing a webinar. If you haven't learned about the Minnesota paid family and medical leave that's going to embark here in 2026, there are changes that you need to do as a practice owner. And maybe you've already had this training, but I just wanted to invite you. It's on October 9th. And if you wanted an invite to that, you can email me and I'll give you my email address at the end. But in that presentation, we have an attorney, Lisa Netzer with True North Transitions, who goes over all of the things that you should consider and what you have to change as a practice owner for the paid family and medical leave. And then I combine how to survive and thrive with short-term team members. So if you have somebody out on maternity leave that's paid, right, going forward, and you're going to have a stranger in your office, I've been there many times as a temp, that how can you be successful in that regard? And so also a little bit about my background. I graduated from the University of Minnesota School of Dentistry in the dental hygiene department. When I graduated, I had the opportunity to work in over 45 different practice settings. At the time, when I think back to starting my career, I never wanted a position that was full-time, 9 to 5, one office. I was very curious. I wanted to meet as many dentists as I could, as many dental professionals. I wanted to see as many practice settings as I could because I just wanted to see what all of this was about. I also remember walking the Star of the North as a student and very, very young in my career, looking at all the professionals, like how did they get here? How did they served all of these private practices? And once I started temping, I started to get really, really, really interested in the business side of dentistry because I could be at an office one day where everybody's happy, the patients are accepting treatment, everything is flowing really nicely. And literally the next day, I could be at an office down the street in the same city, and it's complete opposite. Patients are upset, everybody hates working there, nothing works. Like there's no systems or rhyme or reason to what we do. And so I thought to myself back then, like, both of these private practices are trying to achieve the same thing. One is failing, one is not. And why is that? So again, I was very curious. Um, I started to, at the time, I had owned my staffing agency with my partner. And so I was already a business owner at the time. I was practicing, doing all of this. I went back to get my MBA just because I wanted to. I didn't have to show it to anybody. I went to Hamlin to do that, and that was a lot of fun. But while I was temping in one of my offices, they approached me and said, "Hey, Shannon, our practice manager is retiring of 30 years. We're buying this practice. Would you like to be our practice manager?" And I was a temporary hygienist that owned a staffing agency at the time. And I very politely, I don't know how I said it, but I very politely said no, thank you. Cause I'm like, oh gosh, I don't want to be stuck on this practice. Like, I don't want to be a practice manager. I don't even know what that means. But after a lot of discussion, I ended up taking the position, which was one of the best experiences in my career, in that I went from a clinical chair to running a two-doctor at the time. I mean, this was almost 10 years ago, $5.5 million practice of just doing bread and butter dentistry. 6 hygienists running a day, 25-ish employees. And so I was in charge of all of this. And then I had no clue what anybody did at the front at the time. So I sat down and I learned everybody's position. How do we follow up on claims? How do you really attack an aging AR that has snowballed into an unbelievable amount? How do you work with the accountants and financial advisors? And how do you lead a team of this magnitude and make sure everybody's motivated? So I was there for 6 or 7 years and ended up coaching, which then I landed into coaching and consulting and have been doing that ever since. So it's been a very, very fun journey for me. With the evolution of a dental hygienist, essentially when the hygiene position was created by Irene Newman, it was meant for educating. A hygienist was meant for going into schools and educating kids on how to brush better and about better oral health. Hang on one second. I'm going to make sure nobody's in the waiting room here. Nobody's in the waiting room. Okay. So I think we're good with our 7 participants. So that was the role, was to go, within the schools, educate children on the importance of oral health. And then after that, it came to reducing bacteria that caused caries and creating a clean working environment for restorative. That's what the hygiene profession was up until now. I would say, I don't even want to put a number of years on it, maybe the last 5 to 10 years. It has evolved to not only reducing the bacteria that causes caries, creating a clean working environment, of course, for restorative, but reducing the bacteria and disrupting biofilm that causes caries, permanent bone damage, systemic diseases. There's so many things that we expect from the dental hygiene profession even now. 1945, Gracie Curettes, all of these timelines are a distinction of how the profession has evolved over time. 1950s, the ultrasonic scaler came out, and it's amazing that even today there are hygienists that don't utilize it or don't feel like it is an important part of the appointment. Scaling and root planing came out in 1996, but only the 4341 code, which is the quadrant code. In about 5 years later, the localized code came out. So sometimes we'll see that a practice with more seasoned hygienist is like, yeah, I'm really good at treatment planning, quadrant scaling, and root planing, but I don't quite know how to use that localized code in a right manner. 2003, hygienists were able to provide restorative functions. I have my restorative functions, able to place fillings, do adjustments, all of those things. 2024, we're able to deliver local anesthetic. We have the dental therapists that are coming out, which isn't really related to dental hygiene, but it's an evolution of the profession. 2017, our perfect code came out, which is 4346, scaling in the presence of gingival inflammation, which I'll talk about today. But that was the perfect code to bridge a healthy patient and a perio patient. And so again, this code came out in 2017, and there are still offices that aren't utilizing it, and you may be one of them, which you're not alone if you are. It's just how to incorporate the code, set the fee, file it to insurance, whatever that looks like. We would help you with all of that. And then for those of you who don't know, we had some exciting, well, I shouldn't say exciting because it's very controversial. In 2025, April 3rd, you may or may not know this, in Arizona, they passed a new position, which is called an oral preventative assistant. Essentially, it is a licensed dental assistant that now is able to scale on adult patients with the 1110 adult pro fee, as long as they are qualified to be in that 1110 adult pro fee. So they're kind of blending the scope of practice and training them to be dental hygienists to close that gap of how hard it is to hire a dental hygienist within the practice. And so again, very controversial. But what I want to encourage you to think about is Minnesota, we're pretty progressive in that. And so the question is, will that ever come to our state? There are a lot of other states that are, piloting this as well. And the answer is probably yes. This position will be a position at some point. It may not be next year or in the next 5 years. But the interesting part about this position, if it gets implemented in our state, as a practice, you really have to have a perio program in place, because you can't have your entire patient base in a group of the 1110 healthy individuals. And so if you don't, it would be really hard to say, hey, you take this column because we know that these patients are healthy. So that comes down to the importance of implementing a perio protocol with that, which is kind of interesting to think about. Minnesota has already passed the local anesthetic for the dental assistants. I can tell you the U of M must be super busy, because almost all of my clients are sending their entire dental assisting team to go get certified to deliver anesthetic, because it allows the doctor to stay in what we call, and I'll talk about this later, our zone of genius. So the more that you can delegate and offload and have your assistants practice to the top of their license, and your team members practicing to the top of their license, you can focus more on dentistry and what your zone of genius is with that. Now, the buckets of health. When we have a patient that comes in for a recare appointment, they're going to fall into three different categories. They're going to be healthy, they're going to have gingivitis, or they're going to have periodontal disease. It really doesn't fall into anything else besides that. Full mouth debridement code is a different topic, which is an exciting code to use. There's changes with that code, but for right now, we're going to focus on the standard 3 buckets of health. When your patient presents with 1 to 3 millimeters of pocket depths, less than 30% bleeding, in your scaling mainly above the gum line, that is a 1110 healthy patient. And those patients deserve to be on a 6-month recare interval because they're healthy. They present with gingival health. Our patients that have more than 30% bleeding is the diagnosis is moderate to severe gingivitis. So we would code, because the ADA code of ethics is code for what you do what you code for. We would code for the 4346. We would also charge more because that's a more difficult patient. And we would have them back in 3 months to assess because they have a level of infection that I'm uncomfortable with. Great news is this can be reversible, but if not, it can lead into permanent bone damage. So for that, I'm going to go ahead and see you in 6 months or 3 months, excuse me, and they're on a 3-month recare interval. Then we have perio. That is with, once you do scaling and root planing, they fall into this bucket. You'll see 25%, 25%, 50. Okay. A lot of times when we do a practice analysis, 80 to 90% of a typical practice is in this prophy bucket. And what that means is I always tell doctors, your hygienists are showing up. They're doing the best that they can with what they have. They're truly doing a service to your patients and they're trying to, they're not, not cleaning their teeth. They're just not coding correctly and they're running behind because of it, because they're coding out a 1110 for everybody. So developing a perio protocol is really, really important. Now, when we work with practices, we work with solo doctors to group practices. We have a client in Iowa that has 5 locations. We work with everybody at every different skill and performance level. And with that, sometimes comes a hygienist, whether seasoned or a new grad or whatever, that is like another thing that I have to add to the appointment. Everybody wants us to add more things to the appointment, but we don't get more time. Right? You guys, I can talk like this because number 1, I'm virtual. And then number 2, I'm a hygienist, right? So I'm one of you guys. And I've been there. So another thing that we have to do, but we don't get more time and all of this. But all of the innovative advancements are kind of like, here, we're going to take this away, but have you do this. So electronic records, we're no longer filing charts or writing things on 3 different pages or not able to read something, right? We have digital x-rays. Everything's instant. There's no more, figuring out the phosphor plates or dipping. Gosh, if you guys were ever a part, I did that one time in my life, but like dipping in the dark room or developing x-rays, everything's so instant, right? So yes, we're adding more, but we took away some inefficiencies over time. We have AI interpretation of x-rays. Our clients use either Overjet or Pearl is another company, or it could be a proprietary software that's really interpreting the x-rays on your behalf, and you can use it as a guide. It will show you bone level, it will show you incipient caries through the dentin, and it really allows for guided, right, diagnosis with the AI. Instrumentation, we have ultrasonic instrumentation. There's different, mini curettes, extended shanks, diamond coated curettes, all of those within instrumentation. We have intraoral cameras. We shouldn't have to pull out a mirror and show a patient. All of this takes time. Double monitors are really good for if the dentist comes in for an exam and you have to be writing notes, from a time management standpoint, and they want to have the x-rays up. So that's another thing that saves time. We have instant messenger typically within our practices. If I need something from the front, I'm going to shoot, whoever at the front a message. If I need something from the doctor, I'm not getting up and degloving, unmasking, washing my hands and walking around which by the way, it's 100% chance I'll get stopped about something that is not relevant at that time. And all of this takes up time, right? So we're creating efficiencies around this. When we create efficiencies, we have opportunity for additions, like uh, generally speaking, a hygienist, especially with our practices that we work with, there is an expectation that they're co-treatment planning. I don't like to use co-diagnosing because we get a little bit antsy about that word, diagnosing and hygienist in the same sentence, but teeing up treatment, co-discovery, right? What does that look like? We're expected to provide comprehensive care. It's not just prophy and bite wings anymore. It could be prophy, bite wings, fluoride, maybe some subgingival antimicrobial, maybe it's an electric toothbrush or a water floss. Like we really want to provide a comprehensive approach for our patients because they're going to be healthier because of it. We're expected to know how to properly care for implants. We have a great implant course if any of your practices are interested in it, but essentially implants are becoming so popular. But in reality, hygienists, if a patient has an implant, we kind of look at it sometimes and say, well, it looks good, so I'll just cruise around it because they might not have the tools. They might not have any of the armamentarium to carefully care for that implant. And there's so many things with that within our course. And then unreasonable hospitality. This is an expectation not only for our hygienists, but for our team when we're in private practice. And I assume everybody in our audience is in private practice. We only work with private practices. And it comes from knowing your patients. When we do chart audits, when I managed a practice, this is probably I always say everything's so important. One of the most important pieces of the appointment is how are you going to personalize that to your patient that's coming in? So when we did chart audits, my expectation was if we did a chart audit, there would be a little line. So-and-so's going to Florida. So-and-so just got a puppy. So-and-so, whatever, initials, date. It doesn't take a lot of time, but it goes so far when I see them the next time to say, hey, how is the puppy? Is he behaving? Is he doing this or whatever? Even if I've never seen the patient before, Dr. So-and-so told me about your puppy. Okay, let's talk about it. Creating that personalized touch. Everybody in this room has been in a situation, whether it's a medical situation or whatever, where you felt like just a number. And in private practice, you cannot have your patients feel like just a number. An example for me, you guys already know I have a lot of kids, right? At an OB appointment, a doctor comes in. My normal OB is out. Another OB in the practice comes in and he shakes my hand. He goes, Shannon, I'm Dr. So-and-so. I am so delighted to meet you and be with you today. And I just blurted it out. I said, well, I'm pretty sure you delivered one of my children. Like he was on hospital rotation and his face turned red and I just like blurted out. I didn't care. But he just like his face turned red and it's just like not only have we met before, but we've like really met before, right? Like we're sharing a personal experience. But how awesome would it have been with just a simple chart prep, a simple notation somewhere to be like, hey, Franklin, how old is he? Like 3 now? How's he doing? It's been a long time. Like that goes such a long way. And it also goes with, there's a book called Unreasonable Hospitality, and that's where I got it from. I can't remember the author, so you'll have to, if you can't find it, look for it on Audible right now. But if you can't find it, message me and I'll send it to you. But it's about restaurants in New York and how within New York and anywhere, if you want to be a 3-star, a 4-star, a 5-star restaurant, you have to have unreasonable hospitality. So this author is talking about what are the criteria in having unreasonable hospitality. So he went through one of his restaurants and he's like, I'm going to nitpick everything. Like, what am I noticing? I really want to get to that 5-star level. One of the things that he did not like, which it correlates with dentistry, is that his hosts, so when the guest came into the restaurant, everybody had to have a reservation. It was that kind of restaurant, right? The guests came in, they were greeted by a host staring at a tablet who was very kind, by the way. And it's dark in there, so there's a little bit of glare, and there's this host stand. And he goes, it seemed very transactional. Like this is a typical way you would walk into a restaurant. but I want to be different and I want to have unreasonable hospitality. So some of you may think this is creepy, but go with it. So what he did is he took the host stand away, he took the tablets away, and he had his host team come 30, 45 minutes early to shift. And part of their job was to research who was coming in. Everybody had to have a reservation. And had we seen the guest before? What can you, this is where the creepy part comes in. What can you find them on the internet? Can you find a picture so we can personally greet them and know who they are? Are they celebrating a birthday? What can you find out about it? So when I walk in, it's not like a name, blah, blah, blah. It's like, Shannon, we are so happy you are here tonight. I heard you were celebrating a birthday. Thank you for coming in. And it's like, wait, what? And that's different, right? And so creating a different culture, a different customer service level within your practice is going to boost everything, and generate more referrals and increase, treatment plans and everything like that. There is a small gym that I worked out at for quite a while called Discover Strength, and I absolutely love them, but it's really far from my house. But one of their events that they had every year for their trainers is every day is opening day, every shift is Super Bowl, every client is Oprah, if you like Oprah. But I love it because ever since I started working as a dishwasher when I was 14 years old, I had the mindset that if I'm going to be away from my family and my friends, and even in dentistry, and when I'm seeing my patients, I'm going to make the most of it, because why would I just be here going through the motions? I have a really bad reputation of running behind as a provider because I try to squeeze so much value into the appointment. I want my patients to be wowed. I want them leaving very content with what they're going to be doing. I want to open their eyes to opportunity. One of the things that we coach on is how to solicit a chief concern. And a lot of times when we are observing hygienists, their backs turned to the patient and it's like, does anything bothering you today? And it's like, boom, boom, boom. And everything's no. But instead, what I like to do is get in front of the patient and say, all right, let's talk about your teeth, whether I'm sitting in my chair or I'm standing. My eyes are focused on them, not at my computer. We talk about the 3 F's: functions, features, and feelings. So the first thing I'll say is, how is everything functioning? Are you chewing well on both sides? And you're kind of prompting them, right? Not just like, does anything hurt? That's a yes or no. But they'll say, oh, yes, or no, I only chew on this side. I've only chewed and then we start talking about the missing tooth, right? That's crazy how that happens. Then I talk about, how does everything feel? Like ice cream, anything when you eat sugary, do you get any zings anywhere? Anything sensitive to you, right? I'm getting at what we all ask for all the time, yes or no. And then the last question is, when you see your smile in pictures or in the mirror, do you have any questions on what anything looks like? And right there is where you'll get the 40-year-old guy that you think doesn't give a rip. That's like, I don't know, I have these crooked teeth right here, but I mean, I'm too old for braces. Or I have this black triangle, or this, I really don't like the color of this crown. I noticed that in pictures. It's a lot better to say that than, what would you change about your smile? Or, and maybe you guys have some other tips for me, right? Why invest in your hygiene team? 30 to 35% of the practice production. I'll tell you that again, I work with only private practices. I'm not saying anything bad about DSOs or corporations. There's a lot of things that private practices excel at. And one of the things that a DSO or a corporate entity excels at is managing how they care for patients from a numbers perspective. In other words, there is never any undiagnosed perio in corporate because they're watching procedure numbers to make sure it's in line with the national standard. Now, we could go back and forth about ethics all day, right? But the fact of the matter is, in private practice, we just don't pay that much attention to the largest group of providers besides the dentist. We kind of let them do their own thing, sometimes be on their own island. There's no leadership involved. And so it's really important to invest in your team. Your hygiene team feeds 80 to 90% of your ops schedule. So it's very important that they're always full, that they're productive, that they're co-discovering treatment with you. They spend the most time out of any person in the office. Your patients love the dentist, but they love the hygienist, and they also love the assistants, whoever they're spending the most time with. The hygienists really set the trust meter. They provide clinical closes for restorative cases. Having a talented hygiene team attracts top talent. I had a client reach out to me. I always ask every client, what's the tipping point for reaching out? There's a variety of reasons. Oh, my hygienists want more money and I can't seem to figure out how to do that. Or everybody, whatever the case may be. And this particular doctor was like, I'm fine from a financial standpoint. The money's not an issue for me. My hygienists are highly compensated, but Shannon, I cannot keep a top talented hygienist in my practice. And I said, why? He goes, there's no systems in place. Everybody has their own perio protocol, what they think that they need to be doing. Everybody has their own treatment plan. Imaging is all over the place. And so when I get somebody in, they'll look to their left, to their neighbor and say, what would you do in this situation? And it's completely different than the neighbor to their right. And it creates frustration with the team. And they're like, I'm out. This isn't enjoyable to be, butting heads with everybody and kind of being the black sheep that's diagnosing perio. So when you have systems in place and you really invest in your team, other hygienists want to join that success. With dental hygiene compensation, there are a few ways that dental hygienists are paid. And when I was speaking at the Star of the North a few years ago, there was like 100 dentists in the room. And I said, and I'll ask you guys this, but I can't see your hands. What I asked was, how many of you practice owners would pay an associate dentist a very competitive hourly rate with no regard to what they produce? So like their patients don't show up, they still get that forever and ever. Your associates get that. Nobody raised their hand because all associates are on a comp model. Associates are direct providers of care too. The other two are dental therapists and dental hygienists. So I said, why do we structure our dental hygiene pay on an arbitrary per hour basis that's market value with no regard to what they're producing? In other words, you could have somebody, especially in the cities, demand X, that's a very high number, but in return, all they'll give you is pro fees, which is not only not lucrative, it's not even meeting the standard of care that the Board of Dentistry wants us to do. So it's having them have some skin in the game. And when we introduce comp models, we introduce a base plus a percent of net production if you're a participating provider. And what that means is I'm gonna throw out numbers just for simplicity purposes. If your hygienists are making $40 an hour and we implement a comp model, the hygienist's base rate doesn't change. There's no cut in pay. They still get that base rate, but we're going to reward them by going above and beyond what their quote unquote break even point is within the formula, which I'll show you in a little bit. It's developing the perio protocols, the caries management tools, all of the things that are going to make our patients healthier. That's our number one goal, but we're rewarding them for that. And I can tell you as a high producing hygienist myself that provides very comprehensive care, I love the comp model because I feel justified, rewarded for really, really caring for my patients. But if I was in a practice, and I'm just going to throw it out there, right? If I'm in a practice with hygienists that don't care to practice in that or aren't held to that standard, and I'm just going above and beyond, but I'm still getting paid the same, I kind of have a problem with this. It's not motivating for me specifically. So this isn't meant, when you hear comp model, you guys probably hear of there was a large, I will not name names, there was a large corporate entity that paid commission based, right? You'll hear that too, where if your patient doesn't show up, you don't get paid. And it was kind of a slimy, greasy comp model. This isn't that at all. It doesn't create an individualistic, society within your team. Your hygienists aren't going to hate each other. It's nothing like that. It's only benefiting the practice and the patients and the whole team at large. So with hygiene compensation, we do the third, a third, a third model. If I'm a hygienist at your practice, 1/3 of what my net production is, not my gross production is I charge $100, but if you're a participating provider, you would only get 80 of that 100. Okay, because you'd have like a 20% write-off. So net production, that's a number one mistake. I hear practices who do their own comp formulas. They base it off of gross. 1/3 of what I produce, net production, goes to me from a business standpoint. I have to pay for myself to be in the chair. Also my benefits, my PTO, all of the holiday outings. So again, I always say, I tell doctors this, your hygienists are lovely. They have a strong patient following. They give the patients birthday gifts. I don't know what else nice things I need to say about them, but from a business standpoint, you also have to look at it from a business standpoint. So for a couple minutes, I want you to strip away the feelings and look at them as a person occupying an operatory. So I'll show them, and I'll show you in a little bit what it looks like. 1/3 of what Shannon produces goes back to Shannon. The second third of what Shannon produces goes to expenses. She pays for what she uses, the suction tips, the gauze, the anything, the wear and tear on equipment, future office remodels. Like that second third is what she is producing. The last third goes to owner profit because all of private practices are small businesses and they're owned by an owner, right? Just like Dairy Queen and, well, that's a franchise owner, but you get my gist. And I do a lot of ice cream cone comparisons. So if I opened up an ice cream cone stand, because I wanted to own an ice cream cone stand, I wouldn't sell the ice cream cones for exactly what I purchased the supplies for. So that's not why we went into business. So there has to be 1/3 of profit that the owner can either keep a little or refunnel back in to their team for raises, for bonuses, for outings, for trips, for equipment. And that is how the team gets successful just within the dental hygiene department, looking at that. Now, when we do this calculation, this is a real calculation from one of our clients that we worked with who joined us that one, there's financial issues, and two, he's like, what is going on with my hygiene department? So we did an analysis for him. And as you can see, there's an hourly rate. So this was in the cities. There was the number of hours that they worked. We multiply it by 3 because they have to have a net or adjusted production of 3 times their comp. And you can see, so I'm not going to get into the whole math from it, but you can see that there's a deficit of $436,000 from a financial standpoint. This calculation really shows a hygienist. Like if I worked at your practice and I wanted a raise, and I was hygiene 1, you could show me my numbers and say, Shannon, we love you, but you're not even paying for yourself to be in there or even paying for that expenses portion. And it's not because, Shannon, we're paying you an outrageous amount. It's because that there's a production opportunity and there is a way to strategize your time a little bit better. And we'll show you how to do that. So essentially, this amount of money for this particular dentist should have been on his books in gross production to make sure that all of the hygienists were breaking even from that standpoint. A lot of math involved in there, but this is the background of what we do to look at if a hygienist is overpaid or underpaid. Sometimes we find that they're underpaid, and I'll say, hey, this hygienist is really rocking it and they deserve an increase because they're in the black, $5,000, $10,000, they're doing awesome. And so we also have those situations too, but I would say more often than not, it's typically in the negative. And again, it's not a compensation issue, it's a production opportunity. Practice example, when we work with practices and we do a comprehensive analysis, we base our return on investment on 3 things. 3 areas within the dental hygiene department that they can code differently and they'll get a return. The highest amount was $68,000 a month in gross production. Sometimes it's $12,000 a month in gross production that they're leaving on the table that we can calculate. We guarantee that at month 6. We've never not hit that on month 6. So from an investment standpoint, or if you're wondering, gosh, does any of this coaching work? Will my hygienist grab onto it and run with it? They 100% will. And our job, everybody on our team, when we bring them on our team, is they have to know how to work with people and communicate with people almost more so than the dentistry that they're coaching, because we are not there to flip the practice upside down. We're there to meet the hygienist where they're at. You've seen it all, and everything is like, interesting, tell me more, right? Because it's, you only know what you know. There's no judgment, but then we're going to help you set, expectations and goals going forward and help you along the way with that. Comp model implementation. So, couple things with this. Hygiene comp models are just that. They are not bonuses. If you start saying, oh, I'm going to put my hygiene department on a bonus, your assistants, your office managers, your front office individuals are going to say, how come I can't be on a bonus? And not that a bonus is bad for a team approach, but I want you to focus on a direct provider of care and how they're being compensated at the practice. So when you say comp model, that is just how the hygiene providers at this practice are compensated. So they're on a comp model, and they have goals to reach with that, and they have a number to break even. That's just how they're paid. A perfect scenario is having a comp model for your hygienist and then a team bonus structure that some of you may have, and we also implement. Our team bonus structure is very much a daily goal operation where you meet a goal on a daily basis. And if the team meets a goal, everybody gets extra for that day. The next day we start over. It's kind of like a water intake goal. Daily is best, right? I don't want a quarterly water intake goal. I will give up after day 2, right? But if we start every day as if it's a new day, and we look at lunchtime to huddle to see where we need to be at, just in terms of scheduling in a very productive manner, not diagnosing things that patients don't need. We don't do that. We don't diagnose perio when it's not there, but it's there. We just have to see it and code for it. So a lot of times I'll get, hey, we implemented this hygiene comp model. Our hygienist did so well. Look at what I'm paying them. I just had this happen in South Minneapolis. And I said, did you pay them yet? And he goes, no. And I say, don't, because you calculated it incorrectly. So we got on the phone. And so I went through, so some of these comp models that we're figuring out on our own, we just have to make sure that they're in line and they're calculated correctly. When we design it, there's a 2-layer approach. They have to meet clinical standards of a perio percentage at the top, fluoride, all of that. And those can be interchangeable based off of the needs and wants of the practices. We have doctors that are really into Invisalign that want their hygienist to tee up Invisalign cases for them. Curidont is another product that practices are using. Fluoride varnish, right? That could be another KPI to reach. But once they reach those goals, they get additional compensation on a monthly basis. We create guidelines. We have a whole packet of guidelines of this comp model. All of the questions that have ever been asked or scenarios that a practice has ran into on paying the hygienist. And I deliver that to the whole team to say, hey, let's get these out of the way right away so that we know what to expect when this arises. What do you do for courtesy work? Does product included? How does PTO work? All of those things that we help figure out for you and implement with your team. We also model it out because we want to show the hygienist, hey, if you were on this model last month, your most productive month, arguably, because you've implemented everything that we've coached on, this is how much you would have made. So these aren't arbitrary numbers. You can see literally how much you would or sometimes wouldn't have made. You might look at it and say, gosh, I didn't even make any goal and I have some work to do and I need some help in this area because I'm struggling. And then we present it, and then we also utilize it for hiring. Comp model is a win-win for patients. Patients are healthier because of it. The hygienists love it because they're compensated for their work. Owners love it because everybody's falling in line with the systems, but also it puts you at a very unique position for hiring. In that, we have hygienists in the cities that made $75 an hour on the comp model. And so when that particular practice is hiring, they can put starting at 60, starting at 58 with unique compensation model. Or you could even say starting at 65. Then the hygienist, as I'm scrolling, I'm looking at jobs, I can say, wait a second, what's that about? And then I click on it. That's what we want to do in recruiting. We're not trying to trick them. This is serious. This is what hygienists make there. Then when they come in for the interview with the practice manager or the doctor, they can sit me down and say, hey, Shannon, we have a unique compensation model that we use at our practice. Our highest producing hygienist made $75 an hour last month. Our lowest producing made 58. Based off of where you're coming from, I would assume that you would be in the higher percentage. And this is what they're doing. So now, whatever you put on that ad, you don't have all of your hygienists coming into your office saying, I didn't start out at that rate, because everybody's compensation is ambiguous. It's based off of your level of what you're providing for your patients and how, I have somebody in the waiting room. I don't know how long they've been in there, so I'm sorry. So I just admitted them. But it's nice from an owner's perspective, because when we're recruiting, we'll say you have to up that comp a little bit more. And they're like, well, I can't, because I have all these other hygienists that make, so it puts you in a weird situation. So there's lots more to the comp model, but I hope that you would consider it. And maybe this has helped kind of not debunk, but lessen the negativity around it, because it's not a slimy, greasy corporate comp model that you don't get paid if your patient doesn't show up. So you put me on a comp model. I'm working in your practice. I am super excited. And I've worked at your practice for 10 years, right? That's all I know. And I go up to you and I say, how do I be really successful on this? So I have to have the tools now. I need to know how to be successful if you're going to give this to me. And so there's 3 things that are going to help me be successful. One is my comprehensive care mindset. So we use a tracking system that tracks the individual performance of each hygienist in the office. Each column is a code or procedure that they are providing as value within the dental hygiene appointment. Think of each of these columns as a tool in a hygienist tool belt. When a hygienist graduates from whatever program, could be MSU, U of M, whatever, they have over 35 different tools that they test out and comp out on. They know how to talk to the patients about. They literally have an instructor look at them and do an exam around it. But then when they get into private practice, that scope of practice gets smaller and smaller and smaller, because this group of codes is easy to talk about to the patients. This group of codes is covered by insurance. I start to feel as I get more into practice that if I am providing this scope of practice, I'm over treating or I'm selling. There's all this negative connotation with that. But the fact of the matter is when you re-expand that scope of practice, your patients are healthier. You guys are going to get so sick of me saying that, but I just want you to understand that. When we measure performance, and this is where the fluoride varnish comes in too, we measure it at an individual level. And the reason is not to be like, why are you so low in that category when your peers are so high? What are you doing wrong? You're not being a good provider. It's not to belittle anybody. It's to say, okay, all of us are seeing the same demographic of people. One is able to achieve slightly higher or where I want to be. Talk to me about how you're doing that. Share with me your practices in addition to what Shannon's talking about or what my office manager and my doctor's been trying to coach me on. And so we do that. And another reason we do that is we want calibration between all of our hygienists. If there's doctors in the room, which I know there are, all of you have different scopes of practice. One of you could be a little bit more into clear aligners. One of you can be very comfortable with third molar extractions or molar extractions in general. You all have your own scope of practice. That is completely normal. But what's not normal is every hygiene team in each private practice do their own thing, have their own scope of practice. Every hygienist should have the same scope of practice. Not to mention the hygienists within those walls definitely need to have the same scope of practice. And what do I mean by that? When there's discrepancies in care, we decrease trust with our patients. So think about that husband-wife scenario. They come in, they have similar oral hygiene, right? They have a little dental date, and then they get in the car and they're like, oh, how'd it go for you? And the husband's like, oh, well, I have to come back in 3 months. I had a lot of inflammation. She used a new code on me. Not that we talk about the code, but go with it. I got this new fluoride varnish, and that wasn't as bad as it was before. She also recommended that I use a water pick. So I'm going to think about that and maybe do it next time. And she was super nice. So I guess I'm going back in 3 months. And then the wife's like, what is fluoride varnish? What, like, why didn't my person bring that up? Why didn't I have to come back in 3 months? Why did she tell me 6 and she told you 3? And all of a sudden it's like, okay, we were at the same place at the same team, but we're receiving different, and I get it, it's different patients, but you guys know where I'm going with this. When that happens, everybody's radar goes up. Your treatment plan acceptance goes down. Your referrals go down. Your profitability for the practice goes down. Your potential for a raise goes down. It's a snowball effect. So we really need the entire, whether it's 2 hygienists, even if you have 2 hygienists on your team, really need to be on the same page from that point of view. This, when I told you that we had a hygienist in the cities that made 75 an hour, this is her statistics. So I started with her. I was warned by the doctors that there was going to be an individual that was going to give me a run for my money. And I said, I'm up for the challenge. I'll take care of it. She'll be fine. And boy, did she. She was a spitfire, and I love her to death. But I believe everybody has to be coached in a different way. Everybody has their own personality. Everybody has their own motivations in life and professional, and it's the way you present things. And we really hit it off. She is great. We text case studies. She's a fabulous provider, but you can see the stark difference in her provider performance over the course of 3 years in working together. She saw less patients, and she earned more money, and her percentages went up. And this encompasses the philosophy that we coach in really slowing down, treatment planning what's right underneath our nose in terms of our patients, not looking for more. How can we shorten hygiene appointments and how can we do this? That's not what we want to do. And when we slow down and treatment plan correctly, magical things happen with our numbers and our patients' health. We also look at co-treatment planning. So when I'm in private practice, the expectation of the doctor that I work for is that I tee up treatment. I love it. It gets me out of the I don't know, hygiene's not boring, but go with it. Like the repetitive motions of it that, gosh, my doctor really trusts me to tee up cases. I've teed up anterior cases to the point where before she comes in for an exam, I had a patient that's like, I don't really like the color of my crown. The metal's showing. It's pretty old. I'm like, great. You know what, Dr. So-and-so can do is replace that. But when we look at a smile line, we don't like to replace single units. So we do things in pairs, 4s, 6 units. Oh, well, I hate the color of these. Points to the canines. All of a sudden we have 6 units. Take an IO photo, discuss it. And I'll say, hey, we're going to get you back for a smile consult. But when the doctor comes in, we'll let them know. Doctor comes in, Shannon, can you give an update? I go through my spiel and I'll say, just so you know, we are going to reappoint them for a smile consult to redo the 6 units on top. All she says is great plan. That's all. Exam isn't long. She's not talking about the molecular molecules of a veneer and the process. It's relying on your hygienist. Same thing. Not that I'm diagnosing, right? But MOD amalgam on number 2 has fracture lines everywhere. Take an IO photo of it. Typically in this case scenario, show the patient, right? You have an old amalgam, 3 surface filling, you have fracture lines. We don't have a magic ball on when that tooth is going to crack, but what we don't want you to do is come in on Christmas and have it fracture down the root. We don't know how deep they are. Our best case scenario is a cusp comes off. And that could be tomorrow or it could be in 15 years. We don't know. But I know in this situation, the doctor may want to put a full coverage crown on. And this is what that process looks like. I'm not diagnosing. I'm teeing up treatment. Doctor comes in. Shannon, can you give me an update? Yep. We did discuss a potential crown on number 2. We were wondering what your thoughts were on that. Good plan. So it's been my goal when I'm in private practice. I love my doctor. We're on the same page. Invisalign. They're going to get a scan for Invisalign afterwards. Perfect. Great plan. Implant cases, aesthetics, Botox for therapeutic, for grinding and clenching. All of that, I'm helping co-treatment plan with my doctor. And I know that some of the hygienists potentially on this call or in the room aren't there yet, but it is a very, very special place to be because your doctor is trusting you and helping you tee up cases for them. There's different codes for exam. There's limited, periodic, comprehensive oral. The D0180, that's very underutilized in practices. We want to use that for our perio patients. If you're not using that, you're leaving revenue on the table and also not coding correctly. So lots of things in terms of production. Now, when I talk about time management, the number one reason when we observe hygienists is that, oh, I want to talk to you about something. Fluoride. See how it's in single digits, 6%? When we coach on fluoride, this gets up to 75. It has had an exponential increase since the change for the ClinPro Clear. And because it's patients love it more. It's like, okay, I can only have to wait 15 minutes. It's clear. It's not, slimy and gunky. And even, I took my twins into the pediatric dentist, and the last part of it, and I love their dentist, but it's like he slathers on all of the fluoride varnish, and my 3-year-old gets up and like, it's disgusting, right? But if we had the water base, it's going to be a bigger acceptance for that. Number one reason hygienists run behind when we observe, number one reason is not the forms that are not completed at the front. It is not the waiting on the exam time, although that can be annoying, right? If we don't get an exam on time. It is because we are doing bloody prophies twice a year for 60 minutes. We are running behind because we're doing bloody prophies or perio as a 1110 twice a year for 60 minutes. So when we talk about time management, we talk about the 20-20-20 rule. 20 minutes of assessments, yes. I mean, I literally look at the clock to make sure that I'm getting the most value in this blue area. I'm taking x-rays, I'm taking blood pressure, I'm looking for restorative treatment plans, I'm fomal probing, doing all of these things for 20 minutes. Right at this point, I'm paging for an exam. And then I start my prophy or the cleaning portion, right? Perio maintenance cleaning or gingival cleaning. 20 minutes I'm allocating to that. There are people that will say, Shannon, if you're going to clean my teeth for 20 minutes, I will never see you. Okay. But I would encourage you to time yourself, because if you're scaling, this is scaling to flossing and polishing. If you're scaling for longer than 20 minutes, this is not a 1110 that comes in twice a year. I guarantee you. Then you have the rest for exam notes, cleanup, and prep. When you spend 20 minutes for assessments, your exam is very short. You can do a really good exam in 3 minutes. I've had it happen before. But if my assessments are only 10 minutes long, my doctor has to be in there for a longer time, because guess what? Shannon, can you grab me the IO photo? Can you put the sleeve on it? Can you put it on the computer? Take the IO photo, sit patient up, explain what they're seeing. So we want short exams. If we're prepping the patient ahead of time and they're hearing it 3 times, treatment plan acceptance is going to go up. Your exam times are going to be a lot less. Unproductive time. This is another key factor in overall dental hygiene profitability. So when we look at that compensation to production benchmark, and when you're in the red, sometimes that is due to unproductive time because it counts all of the time, the hours that you're clocked in, okay? So unproductive time where you're not actively producing is prep time. So I get in 45 minutes before my patients and I prepare. We have a system that we do. I literally know their shoe size before they get in, because it comes back to that unreasonable hospitality. I'm ready to fire at every opportunity. I don't have to look things up. I'm very prepared for my patients, and my production shows because of it. So it's prep time. Note time. Really, there are times where I can't get to my notes until the end of the day. There are times where I'm really rocking it and I'm catching up in between appointments. That's unproductive time. So you can produce a lot, but if you're hanging out on the clock and kind of not managing your time well, you won't be profitable in your chair and you'll be in that red. These are some of the factors. changes in the schedule, and I have those in quotations because we don't use the word cancel in any of our verbiage, because nobody cancels at our practice. We don't have a cancellation list. We don't have anything that involves a cancellation, but we do have changes in schedule. And the more changes you have in your schedule means that this is a hard pill to swallow. The majority of the number one reason patients fail their appointments is because they didn't see value in the chair the time before. So if I'm not instilling the value of making sure that you come back, because we need to check that one spot, do you remember that fracture line? We need to make sure it doesn't get bigger. I need you back because you have infection and bleeding. I need to have you back, right? It's not, I'll see you next time. I'll see you in 6 months. Which one am I going to cancel first, right? So I have to create value and own it as a provider. There's also the fact of not having a cancellation and failure policy. So if I'm working really hard as a provider, but our front office is just letting people in and out and they get to schedule the next day and all that, that doesn't help me on my comp formula. It doesn't help me with my profitability or whatever numbers that the owner is going to look at. Finishing early. I told you I run behind a lot. Always have. I don't understand. I'm a big proponent in 60-minute appointments. I don't understand how consistently a provider can finish at 30 minutes and just be done. There's so much value that the patients pay a lot of money, and I get some people want to get in and out. I get that, right? But they pay and they invest so much with us, time, money, all of that we owe it to them to fill that appointment with value. And so finishing early to me is unproductive time. And then just general duties. This is where I'm glad I'm virtual, because then I can't see anybody's reactions or nobody can throw anything at me. But the expectation sometimes of management, the owner, the team, like hyper focused on the noise that is the dental hygiene position or the task. That's where the diva was born. Okay. We can't lie and say that we've never heard that hygienists are divas. I'm one of them, so I can say it. Where did that come from? Okay. And I get that. There's names for everything. But when I talk about the noise, I talk about the Pareto principle. Some of you may have experience with this, but the Pareto principle was developed by an Italian economist that observed that 80% of his healthy peas came from 20% of his pods. 80% healthy from only 20% of his pods. So what does that mean? It means that 20%, so out of the 10 things we do at the practice, whether you're a practice manager, whether you're a dentist, whether you're a front office individual or a hygienist, if you think this is a good exercise for your next team meeting, list out 10 things that you do when you walk into the practice. 10 things. And then I want you to circle what the practice only needs you to do. So for a hygiene example, you're going to list walk in, start sterile, do the x-ray test, make sure my room's stocked, prep my charts, see my patients, write my notes, sharpen my instruments, whatever. Out of those 10 things, what requires a dental hygiene license for? There's gonna be 2 things: seeing patients and prepping your own charts. Dentists, if you're packing cord, if you're taking your own impressions, if you're making your own temporary crowns, if you're doing your own notes, those are the noise of your job. The hygienists have a noise of their job. So what am I saying? That the hygienist should never sterilize instruments? No, and not at all. I am very much a proponent in teamwork and all of that. But when I have a problem, when I am providing the best care, I'm running behind, I'm filling the appointment with value, but then I am like put in this position where people are mad because I'm not cleaning the bathroom. It was on my chore list to clean the bathroom, and I'm not helping and sterilize as much as I could. But guess what? I served all my patients and converted 10 patients today to prophy or perio. So sometimes there's too much focus within what we're supposed to be doing as dental hygienists. That's an added thing. And that's just figuring out what the flow is with your team. Not every team has a float. Not every team can do that, and I get that too. But whenever we start to get frustrated, ask ourselves, what is our unique, we call this 20%, our unique zone of genius, our unique ability, our 20%. It's a very special place to be, and we coach our practices on this all the time. How can we get the doctor in their 20%? How can we get the assistant in their 20%? Maybe we're incorporating a float, front office, all of that. Number of dental hygienists needed. Take a picture of this slide, take a screenshot if you want, but when we're doing an analysis, we can tell you exactly how many hygiene hours you need per week to serve your active patient base. In the metro, 7-county metro, an active patient to us is a butt in a chair in the last 18 months. So a patient in the chair in the last 18 months. In our outstate, outside of the 7-county metro area or our rural practices, we use 24-month active patient count because we have farming communities and we have demographics that we want to stretch that out to 24. That is a better representation of an active patient count in that particular area. We take the amount of weeks in a year, shave off how much you're going to take off. Let's say it's 4 weeks, you get down to 48. We really can tell how many full days of hygiene you need per week. I want to mention that we use this as a starting point. So if you calculate this in your office, I want you to ask yourself, where is our perio percentage at? Because if it's in the single digits, whatever this number was, you need more because you need to kick off a perio program. Why? If majority of your patients are coming in every 6 months and on a 1110, and you start to implement a perio program, your appointments triple or quadruple because all of a sudden they're coming in 3 to 4 times a year. So your appointments really multiply with that. So you're going to need more hygienists to kick that program off and serve that patient level. Do you want to grow your practice? I have a practice right now in the metro that's at a very low active patient count. It's at like 1,000 active patients. She needs a lot of room for growth with that. So we're going to create opportunity for growth by making sure that she has adequate hygienists and maybe even a little bit overstaffed to create that opportunity for growth. Some of my other practices are booked out. They're like, I don't even want a new patient coming in my door. I can't even handle the patients that I have. Well, this is going to be a little bit different than that. Pepsodent. So you're probably wondering, Shannon, how do you know that a patient isn't supposed to come in every 6 months? Like, where does that come from? Where that came from was a toothpaste commercial in 1929 called Pepsodent, and you can Google the little commercial. And it was a little song about this toothpaste, and it says, visit your dentist. I don't even think they said dentist, like doctor, twice a year for your cleaning. And it was to sell more toothpaste. From there, that was how the twice a year was born. So this is a fun fact for your patients. There's no scientific evidence that a patient is benefited from only coming in twice a year. Insurances say that. Some insurances are even 3 times a year, right? But that's literally where it came from. We know the bacteria, especially the periodontal pathogens, replicate every 60 to 90 days. So are we doing a service by not coding out for it and only having them come in twice a year? So that being said, this is based off of twice a year. So we always use this as a starting point and then say, what should it actually be? 50% of your patients should be on a perio program based off of the national average. Your demographic, it might be 40. It might not be exactly 50, but it really changes your schedule and how that looks. Scheduling practices, and I know I'm keeping times now. I'm at 7:20. Scheduling practices. This is another way that I'm going to be successful as a hygienist on this comp model. Appointment length. What is the appointment length like? Do you have a standard operating procedure at the front? Or is it really, really hard to schedule within hygiene because you don't have set parameters? So those are some examples. Periotherapy is always at the provider's discretion. It bothers me, maybe that's not the word, to say like, oh, scaling and replaning is 2-hour block or scaling and replaning is a 1-hour block. Well, I might be able to do a localized spot in, I don't know, 30 minutes if it's not that complicated and I have them back. I might need 2 hours to do a quad and a half because it's so complex, right? And the calculus is hard to remove and all of that. So it's at the provider's discretion. Adding time for obviously ortho, wheelchair transfers, special needs, of course, but we do not add time for typically x-rays. Sometimes I run into that with practices. Oh, my patient needs a foam series. I need to add 10 extra minutes. Those should all be, you should be able to complete those within the 60-minute time frame. Talkative patients. I have a client that's like, well, this patient, like the front office could never schedule for any of the 5 hygienists because there's a parameter for everything. Oh, this patient gets 70 because they talk a lot, and this patient gets whatever. And they could never do online scheduling because it's not set in stone. So we can't do that either. We have to be very friendly with our patients, right? But there's also a time parameter that we have to abide by too. Or my favorite is I schedule extra for this patient because they're always late. So those are some things that we really need to work through as a team. Like, do we need to be accommodating for that? Scheduling to goal. If I want to make a certain amount, or if I want my fluoride percentage to be a certain amount, I need to make sure that I'm scheduling to goal, which involves what production goal do I have each day, and then block scheduling. So this is just an example. When we implement a comp formula, I'll show the team, hey, to break even, you need to produce $1,900 a day. That's just to break even. If you're interested in making 55, 60, this is what your daily production goal should be. If I was them in private practice full time, I would look at that, put it at the top of my goal, and make sure that my schedule is reflecting that. And again, I'm not creating something that's not there. I'm not being unethical in my practice. I'm being very, very intentional of what I have in my schedule. And that comes through blocking for perio, blocking for new patients. We really want to create a rhyme or reason to the dental hygiene schedule, not just schedule 8 to 5. It doesn't help with exams. What I typically find in practices is every hour the dentist is like, do I need to be in there? Do I not? Do I need to be in there? Let's put the patient on a day. I do scaling and root planing on Thursday mornings. Would you like 8 o'clock, or I have an appointment at 11? That's how that works, because I do that procedure on Thursday mornings. So you're really designing your schedule to have it flow better from an exam standpoint. You're not bothering the dentist for an exam. It makes my day easier. It makes the front, like everybody's easier when we're scheduling. Same thing with restorative. We do perfect block scheduling for restorative. We have our doctors create a design. We help them with it. We get everybody on the same page on how to matrix or dovetail appointments, not just plopping anybody in with no rhyme or reason, just to make sure that there's no white spaces. We want a full schedule, but we also want a productive schedule. Fall scheduling tips. This is a list that we recently sent out to our clients because fall time, for whatever reason, tend to be a slower time within dental practices, particularly in our harvest and our farming communities. That is the case too. So this is a great checklist that you can go ahead and take a picture of, and how to make sure that you have a successful fall with your hygiene schedule, but also finish the year really, really strong and set some goals up for 2026. Some of these things that I haven't talked about is pre-appoint percentage. There's companies like Dental Intelligence that will calculate your pre-appoint ratio, but what we really want is 90% of our appointments to be pre-appointed by our dental hygienist in the back. A goal is 90%. Why 90, not 100? Because there's like 10% of our patients that we're good if you don't schedule, right? There's always the ones that are going to give us a run for our money, right? Recently, I had a doctor go to an institute that they study at, and their pre-appoint percentage for their practice was only 70. And I was interested, and I said, why do you only want 70% of your patients to pre-appoint? And they were like, well, because the other 30 is probably not, people that we want back. There are patients that you don't want back. So then we're wasting our time by pre-appointing that. And I said, why do we have 30% of our practice that we don't like? And so we get into how to curate your best patient and how to curate a patient base that values what you do and that shows up for their appointments and pays their bills, right? We shouldn't have 30% of our practice, 10 maybe, right? Not everybody's perfect, but that was the metric behind that. So if you calculate differently or you have a different reason, I'm happy to hear that as well. If you're diagnosing perio and you are setting appropriate recare intervals, your schedule should naturally be full. If you're not diagnosing perio, that's going to be very hard because you can't make up a recare interval over the phone. So that it comes down to correctly treatment planning and diagnosing. Let's see, cancellation failure policy. Again, that's crucial at the front. What happens when a patient, we consider a failure less than 48 hours? That's enough. That's, 24 is not enough time for us to make changes in the schedule. And the more strict you are on this policy, I can guarantee you, I live it with my practice that I'm at right now. I can't tell you if I've ever had somebody not show up, but they have a policy, they adhere to it. It was even, I had one of the dentist's second cousins in my chair, and she said out of her mouth, I almost missed my appointment, but I didn't want to get charged. She charges her own family. I mean, they like stick to this and their patients, and then they're booked out too. So there's that scarcity, but it's really good to have a policy in place for that. Waitlist auto notifications. Nowadays, you're able to, with the click of a button, mass text your entire patients that don't have appointments and say, hey, we had a change in schedule. First come, first serve, give us a call. There's lots of modernized ways that we can fill our schedule without calling, hanging up, texting, the old school way of going through a list. So lots of different options with that. We have end of the year benefit notifications. If you haven't sent out a notification via email or snail mail even, that the end of the year is approaching and to utilize your Flex, FSA, HSA before they expire. That's a really good kind of reminder for your patients to get in during your slow months as well. And then, of course, your last resort is just personalized recare, really working the phone, the text. We have verbiage that we use in a sequence that we go through that actually gets a call back. Sometimes I find with working recare as a last, ditch effort on filling the schedule, the verbiage is, I don't want to say horrible, but it's not enticing. So it's like we almost just spent all this time plowing through a list, saying what we were saying, but nobody is calling us back because of what we're saying, if that makes sense. So we have to make sure you're pretty much selling the fact over the phone, over voicemail, that we really need to see them in the practice. And there's a special verbiage that goes in with that. Next steps, as I wind down and kind of get to the Q&A portion here tonight, is when you go back to your practice, a couple things that you can do. You can identify your break-even point. Are your hygienists overpaid, underpaid? Where are they at? And how can we meet the needs of your individual hygienist on where they want to be at with that? Assess hiring needs, feedback from candidates, owning a recruiting company and interviewing people over the last decade plus. I have a bunch of stories, but what I can tell you is that the more information you get, if you're getting candidates in your office and they're not accepting, you have to figure out why. You have to ask them, give them honest feedback. Sometimes it's the energy that they step into your office and they don't feel the energy. I got a text one time, I've been here for 2 minutes and I already don't like it. I'm like, what happened? She's like, the energy is just weird, like at the front, right? So that could happen. Maybe you're not offering enough for compensation. You need to know about those things so you can reposition yourself as an owner to attract the best talent for your hygiene team. Leadership in hygiene is crucial. Having a team lead really takes the pressure off of the owner, takes the pressure off of the practice manager. The practice manager or the owner cannot do everything by themselves and practice dentistry at the same time. So appointing somebody in a leadership role that can really calibrate the providers, really get everybody on the same page and put them in that position will be very, very helpful. Review your group and performance, your individual and your group performance. If you're not monitoring procedure numbers, start, because it's a good tool for your hygienist to look and see what are we actually doing. You could sit down with them and they could say, I feel like I put fluoride on my patient's teeth a lot. I feel like I use the intraoral camera. But all of that's based off of feelings. We don't know. Maybe it's only 20% of your patients and you thought it was 80. The numbers tell us everything. And then set goals, whatever that may look like with this month, year end, or even into 2026. Lastly, before I get into questions, if you're wondering, gosh, she's brought up a practice analysis a few times, what does that look like? So what that looks like is we take a snapshot of your practice management software and we get information like front office information, collections ratio, claim follow-up. What does your accounts receivable look like? Essentially, from the KPIs or key performance metrics, is the front office health? Is there financial health from a revenue cycle management at your practice? So we look at that. We'll look at your dental hygiene performance, calculate their compensation to their production. We'll look at capacity, how many active patient counts, what's the active patient count, what's your insurance participation, do you have any room to move with your insurance landscape that you have, whether it's trimming out one or two or half. We also bring practices out of Delta to be a completely independent provider. So that's also very exciting. We'll look at strategies like that. We spot check your fee schedule to see what percentage you're at, and a lot of very, very interesting things. After our analysis, we, of course, have a plan, a coaching plan. Should you want to partner with us for all of the things that we proposed or just one or two, we have a plan for you. But at the end of the analysis, there's no obligation to work with us. If you're like, hey, this was great, I have some ideas for my practice manager to implement, or whatever the case may be. So that's what our comprehensive analysis is. We collect the information, we schedule a 90-minute Zoom call with you. We put it together in a great PowerPoint and go through it with the owner. Sometimes the practice manager is there or the other associates as well. With that, I will open it up to any questions that we have.
I don't see anybody raising their hand. I think you covered everything.
Are we sure?
Anything?
Anybody on Zoom? You can drop it in the chat or unmute yourself.
Yeah. Okay, what is the average fee for fluoride? Like, what would you charge for fluoride? And like, just starting basic with that. Could you hear that, Shannon?
Yes, I don't know if Nellie wants to answer it or I can.
You go first, Shannon.
What I see practices charging is between 50 and 55.
So that's accurate, up to 60.
Nellie, what is your answer?
That's accurate. I'd say the highest I've seen is 60. I've seen the highest I've seen is 80, but compliance is low.
Yes. Well, and my goal was to increase compliance, is to not, like, it's the only fee we haven't increased in 5 years. Because I just want them to be comfortable with the number. This is what it is. This is, and it's still police criminal. It's obviously like it's kind of that side. I just was curious where it was at, so I don't want these too far away from that comparison, so.
What, in terms of fluoride fees, sometimes what I find is a practice is so proud. They're like, we only charge, this literally happened to me. We only charge $30 and we get so many patients accept it because it's only $30. And I said, but this said insurance company that you submit to pays $38. So you're not even charging, and he's like, oh. So you're leaving money on the table that and reimbursements cutting. They're not going to pay you $38 when you're charging $30. So there is this notion in my experience that if we charge less, the acceptance will go up, and it's really not the case. I mean, maybe 7 years ago, if you were to ask me 7 years ago, everything was 45. 45 is a great number. 45 is a great number until I saw practices start charging 55, 52, whatever. And the percentage of the fluoride percentage is the same as somebody so it shows that, yes, it plays a factor to a little bit, but just relying on the price of it in terms of patient acceptance shouldn't be a determining factor.
I have a question. So I know you're mainly like focusing on dental hygiene and all that, but I know that you mentioned like dental therapy and ADT, and I was wondering if you could kind of explain how to go about like pay with like the dental therapy and ADT scope.
So same, comp model, more of a comp model than a dental hygienist. Some dental therapists are strictly on like an associate comp model where there's not that guaranteed wage, but it's rather from a production standpoint. With dental therapists, just speaking from my, client's point of view, sometimes when they want to incorporate a dental therapist, they're like, okay, they can do hygiene plus, restorative. And what we find, and maybe you can allude to this, is they don't want to do hygiene. I mean, some of them might help out once in a while. So it's really developing, what they're looking for, number one. And then we find that there's a speed factor involved. So, getting your clinical skills up to snuff is fine, but then in order to be on a comp model to be successful, there's efficiencies that have to happen in clinical practice with placing fillings and just appointment times. So I think it's an ever evolving. I don't know if there's like a correct industry standard because every practice is different, whether you're taking insurance or not taking insurance, whether you're in public health or private practice. But definitely it's a comp model like structure. Do we have any other questions?
It doesn't look like it.
Okay. Awesome. Well, thank you for having me. It was a joy. I wish I could have been there in person, but it just didn't work out. I would just have been flying in from the cities within rush hour. So I'm super excited to potentially return on a different topic if needed. And you have oh, wait a second. Here's my contact information. If you want to take a picture of that, this is my direct email, shannon@dentalconsultingco.com. And then this is the information for our recruiting company too, and that's Erin's email address. So feel free to take a picture of that. And I look forward to seeing you guys in person one day.
Thank you, Shannon.
Yes. Thank you.